So my colleague John Chauvin, who's a public finance economist, has worked on retirement behavior for years, and he, following up on some work Vic Fuchs, another one of my colleagues, has done years ago, said, maybe what we ought to think about, instead of an age at which retirement benefits and Medicare kick in, is rather than picking an age, pick years until death, basically, average years until death. And if you change your perspective that way, you come up with a different set of policies. So this is, the green line here shows what happens to remaining life expectancy. That's what I'd like you to focus on. And in 1935, at age 65, you had an average of 12 years of life expectancy, and now it's around 19 years. 7-year increase in life expectancy over that period of time. That's huge. And the other point of this is to show what happens to annual mortality risk, which is highly correlated with life expectancy. Well, if you change your definition of retirement age from a fixed age of 65 to just a standardized age of years until death, that corresponded to age 65 in the year 2000, we would have 15% of the population in 2050 would be retirement age, as opposed to 20% if we use age 65. Do you see what's going on here? He's saying, look at years until death instead of fixed age. We have much less growth in the retiree population if we switch to this definition. Now, from the point of view of Medicare expenditures, this is the money slide. What percentage of the population would be eligible for Medicare if we switch to a different definition based on years of remaining life expectancy? So this dark blue line at the top shows the projections using age 65 as the criterion. So around 10% in 1970, going up to around 21% in 2050. If you took the remaining life expectancy in 1965, the year that Medicare came into effect, and you just said, we'll keep the same number of years of remaining life, so we take into account advances in life expectancy, we would only have 12% in 2050 eligible for Medicare. And if you do something in between, start the age adjustment at 2004 rather than 1965, you still have a significant reduction to 17.6% will be Medicare age. Is this possible to do? It's only possible if we think that we can keep people healthy, not only living longer, but capable of working when they reach advanced ages. Now, I'm not showing you the data here, but there are data showing that disability rates have also declined. This is work that was largely done by Ken Manton at Duke. It's probably less dramatic than it's been portrayed. It's only in what they call instrumental activities of daily living. There's no evidence of the same trend in activities of daily living, which are more basic capabilities like being able to dress yourself without assistance. But the evidence is there has been some decline in disability rates as well. And, but it may not be going fast enough for people to be willing to commit to the idea of raising eligibility ages for retirement benefits and for Medicare. But I want to show you what this means in terms of earnings. So this shows what's happened to male labor force participation. That is, what percentage of men are actually in the labor force at different times. And if you use the definition of remaining life expectancy, if you look at a remaining life expectancy of 15 years, in 1965, around close to 85 or 90% of men with that life expectancy were working, and in 2005, it's only about 30%. So if we had the retirement policies, the whole set of social policies designed to keep people working that were adjusted for the increase in life expectancy, we would have a huge increase in GDP if we could get the people to work longer. And there's a whole body of evidence that shows, by the way, that people's retirement behavior is extremely responsive to retirement policies. If they can't get the retirement benefits, they just don't retire. It's very small numbers of people who retire early unless they become eligible for their pensions or whatever their form of retirement benefits are. So I want to put to you that the real game-changing challenge here is not about details of how the healthcare system changes, but can Medtech develop the products that will keep people capable of working into advanced ages? And incidentally, as you well know, this is not only about money. It's not only about people's ability to work. It's about being able to enjoy their leisure activities too. Americans are living a lot longer, and the critical issue is about keeping them healthy as they age. And that's really the bottom line, and I want to leave that as an open question to all of you. So I think we have a few minutes for questions. Thank you.
I'm Dr. David Durack. I'm the Chief Medical Officer at Becton Dickinson. At the beginning, you mentioned that interesting number of 95 trillion value of increased longevity since 1970. I had a couple of questions around that. Is that value increased productivity, GDP, or intangibles, quality of life, and so on?
It is intended to be a GDP measure. I think that they did put in some adjustments for quality of life, but think of it as primarily GDP.
Right. And second question around that, you said it was 3x health expenditure. Was that total expenditure or attributable expenditure?
Total. That's one of the weaknesses of this method. It's total expenditures.
And is that ratio changing? Are we bottoming out on that 3x? Is it maintaining that wonderful ratio or not?
I mean, that's a great question. And I don't think anybody's answered that. But let me point out that there's a reason their numbers are a little misleading. And you hit on this, actually, when you were asking if that was attributable. What you want to know is marginal cost and marginal benefit. This is taking total increase in longevity, much of which might have had nothing to do with healthcare. It could have had a lot to do with things like lifestyle changes. So you can't really draw an inference, in my view, that the healthcare was worth it. There are detailed studies in particular areas that show that healthcare did produce huge benefits, and particularly in the area of cardiac care, where we've had dramatic improvements in outcomes for coronary disease and other cardiac diseases. So I think you're asking a very interesting question. I'm not sure it would be fruitful to answer that as much as to look at the very specific types of healthcare and whether they were paying off.